last trial, which I think is really a groundbreaking trial also. I've left, these two trials for discussion right in the beginning and the end. This is called the PREVENT trial. According to me, this trial is going to open a Pandora's box of questions and concerns. Now, this trial was designed for prevention, in the sense of preventive angioplasty, when we have a coronary lesion which is not flow limiting. So please see this trial design. And coronary stenosis 50%, but not significant enough for stenting, with a negative FFR. Please note, the FFR showed that it was not significant, but on imaging, the plaques which were in this group were found to be significant, either with a small MLA, large plaque burden, or a thin cap fibroatheroma on IVUS, or a lipid-rich plaque. So these are what we call vulnerable plaques. They should have at least 2 out of these 3 criteria. And these groups were divided into doing an angioplasty in spite of a negative FFR and OMT alone. Now, as we know, the DEFER trial gave a clear message to us. The DEFER trial, in which negative FFR patients were left alone, it told us that you don't need to stent patients who've got a negative FFR, and it told us it's safe to leave them alone. Very, very few patients had events. Now, in this group, this is completely challenging that DEFER trial, that if these patients had a vulnerable plaque in spite of a negative FFR, they went to undergo PCI with either an absorbed biovascular scaffold or a cobalt chromium everolimus eluting stent. And in this subset, surprisingly, it showed that the outcomes, the primary outcome of death, MI and target vessel failure at 2 years was better in the PCI group as compared to OMT group alone. Not only that, this trial kept on going at 7 years. It still showed that outcome benefit persisted. So not only these causes, but the outcomes of any death from any cause, any MI, this also showed an important, significant improvement if the preventive PCI was done. Now, what does this tell us? It tells us that when a patient has an angioplasty in a vulnerable plaque, as long as they have been shown as a vulnerable plaque on imaging, irrespective of the FFR, it is worthwhile to put a stent for these patients. Now, why this is a little bit of a concern is that this trial was done not, although this gives a message that yes, you have a vulnerable plaque, put a stent. But please remember, this trial had some limitations. It was not done in all acute coronary patients. Remember, the gold standard for a vulnerable plaque is not IVUS, but it is OCT. And not all patients here used OCT. And so this trial did have a lot of shortcomings, because what this trial is going to do is going to give us a very open window to put in stents even in FFR negative patients.